All right, we're starting. I hit the button. I know. Give her one of these. Thank you. Nice to see everybody on a Friday. Go figure. Sorry, the next class I'll have like 6 people. It's all right. Hey, I can live with it. Nevertheless, today is electrocardiogram day. Huh, get your electrocardiogram today. All right, here we go. So, all of what we led up to last time was this. It's a very interesting unit, and I don't know how many. I'm trying to think of a good frame. Okay, so for all the people who are in the nursing field and things like that, oh, I want to work in the operating room. I want to work in recovery. I want to go into critical care. I want to go into ICU, neonatal ICU. Okay, and you're going to work at UPMC. You have to know this stuff, so much so that the fact that you have your GN, okay, and you've got a job there, it doesn't mean they're going to let you work in that unit. It doesn't work that way. They have a training program for critical care units and specialized units. So you have to basically, maybe I told you this, they have a week-long course. They used to. So, and this was maybe 20 years ago, because my first wife, who was already 20 years removed from this, she had gone on board at Shadyside in their like outpatient surgical unit. And so she had to take this course. It was over at Montefiore, which is part of the complex at Pitt. And it's a week. So you're in class from 8 to 5. You have homework every night. And on the Friday, that's Monday through Thursday. On the Friday, you have an exam to check to pass in order to be able to go on to work ICU. And this is one course. It was one course about heart meds. Another one was about electrocardiograms. So it's never too early. And whether they do the same thing or not, I do not know. They may even be more rigorous. Because today the magic word is called vetting. And it means in order for them, they have to certify if they're, let's say, something tragic happened, or even something that's not tragic, but something that they could be liable for with damage happens. They have to be able to say, look at the people on this. Well, how about this person? What information do you have to say that this person was qualified to be at this unit at this time? Be they doctor, nurse, technician, whatever. So there's a lot of that. It's the legalities of medicine that sometimes overwhelm the practice and the art of medicine, if you want to think of it that way. So that's the frame. It's a good frame for this. Okay? Like if you didn't know, as a doctor, when I went on staff at the old St. Francis Medical Center, I mean, basically, the first question is, are you board certified or are you board eligible? If you're board eligible, you have X number of years to become board certified. And so in X number of years, you have to have some kind of board certification, which is a very rigorous course of study. Okay, and a giant exam, both written and practical, to take. And submit a whole bunch of cases that you did. That's what doctors have to do. So the education's already there. Okay, so that's 3 minutes of your lives that you'll never have back. But here we go. So effectively, this is a very useful website. I mean, it wasn't any brilliance on my part. It's the first one I came up with years ago when I said I want some information on electrocardiograms. It's called ecglibrary.com. Forewarned, I will say EKG. I learned EKG with the hard K for cardio from the German. So they're interchangeable terms, etc. So you can see ECG, EKG. What is it? Okay, you've all seen it, and you will see it. Okay, when you typically someone comes in, whatever the reason, in an emergency room or in an outpatient setting, or just to have some tests done before they're having an operation, depending on their age, and they'll put, one of those peel-off sticky patches here, here. Okay, and you'll attach leads to it and hook it up to a machine, and effectively you'll get a tracing. That tracing, that'll appear graphically, now it will be on a computer-like display, it is basically looking at action potential surrounding the heart, and it's adding them up. And if you did not know it, what this basically would look at a series of different leads that are able, and this is not stuff that I'm going to ask you about now or on this exam or anything like that. I'm going to ask you the very, very much the basic, what does each wave represent? some examples of what we call irregular or abnormal rhythms, etc. That's the kind of questions. So this is a lot of this is contextual in nature. So when we see, so effectively, not only do they put the 4 leads on, they have what are called, those are called limb leads. Back in the old days, you put them on your wrists and on your ankles. Okay. In addition to those 4, now we end up with 6 additional ones we call precordial leads because they go around the heart at basically important areas. And you'll see an illustration of an older gentleman having this done. And I've had this done many times over the course of many years. Every time I've had to have a procedure, or sometimes routinely when I'm having a physical, my physician will say, my PCP will say, we haven't had an EKG in a while. I'm going to go get one. Here's an order. Just go in there. When you get your lab work done, they'll do it. This is what it looks like. So if I click it up there, in the old days, this was graph paper. And the graph paper was very useful because it gave you a hint based on the squares. So each one of these big blocks represents a 20th of a second. So 1, 2, 3, 4, 5 of these blocks. This is for your information. I'm going to give you a test on this. That's not code for don't listen. Okay. So 5 of those blocks is a second. And so if your heart's beating normally, it should be beating faster than typically than those 5 blocks. So here's one here. It's 4 and a plus on either side. Okay. So each one of these little blocks is 0.04 of a second, if you wanted to look at it that way. And those numbers are relevant going forward. So you have the limb leads, and they're called lead 1, lead 2, and lead 3. And I don't know whether they're inverted here. 1, 2, and 3. Not quite. This is just a base tracing. AVR, AVL, and AVF. Don't ask me what they mean, but if you hear the names, if you see them going forward, and again, I'm not going to ask you about all those leads that are there. I'm sure RNL must have something to do with right and left. They are effectively telling, and they certainly don't all look the same, but these, lead 1 and lead 2, typically are leads. When you see them on TV, if you see them on a medical show or a documentary, it's probably lead 1 or lead 2. If you walk into a hospital room and the patient's hooked up and you can see up on the monitor, or you're in the emergency room for some reason, hopefully not for you, for somebody else, and you're in there just, being supportive, and they're hooked up, typically it's lead 1 or lead 2. Then V1, V2, V3, 4, 5, and 6 all have to do with the precordial leads. And so you run a tracing like this effectively. Typically, in the old days, we did it on paper. The graph paper went at 25 millimeters a second. That's how you get the blocks. And they print it out now. It's obviously done digitally, and they send it to be read. A little background information. Years ago, we relied on this a lot to determine if someone had a heart attack. We did not have the advantage of having enzymes and scans to look at things more directly. We did what we call serial enzymes that weren't very specific over 3 days, and serial cardiograms over 3 days. Because in 3 days, you would see the changes that would be compatible. And in the meantime, you've got somebody in for 3 days, whether or not it might have been indigestion or actually having a heart attack. So it was different then. Now we have, you guys remember troponin, from troponin and tropomyosin? Now we do serum troponin levels. Troponin can be fractionated. In other words, we can find out which one is coming from skeletal muscle or cardiac muscle, which both utilize troponin. Smooth muscle does not. And if the cardiac cells are damaged, in other words, having a heart attack, they're dead, they release the troponin into your bloodstream. And if you get serum troponin levels of a certain level that are notable, proof positive there was myocardial infarction or heart attack. Just give you some idea. But it doesn't mean these are now most of these are no longer hand read, they're machine read. In other words, they basically have an AI program, for lack of a better way to express it when I say machine read. What I know about AI, you could put inside one of these little containers for the little iPhone, the eye thing there, and I have room for the whole thing to stick in, which means I know nothing. a thimble and you still have room for everything else in the thimble. But because of that, I mean, what happened to me was, maybe I shared this anecdote with you. I went to my family doctor alarmed because I had had one of these done before a physical, and it said, see, at the bottom it said, no change from last time, and at the top it said, evidence of an old myocardial infarction. I never had a heart attack. So I went in there, guns blazing. What the fudge were you doing? And he goes, whoa, whoa. He goes, this is machine read. You didn't have a heart attack or anything like that. It's a real problem we have today. I have a lot of patients coming. Okay, fine. I don't know why they're doing it, but whether it's a glitch in the system or not. So we don't rely on them quite as much. Maybe that's a little bit of the backstory. So this is what we look like for here. So how do we know? And now we'll take a look at this one, and you can jump around with this. That was normal. So I'll go back and show you. So you hear the term, it's a sinus rhythm. What does that mean? And we'll get to it. This is called a P wave. We're going to get to that. This is called a QRS. This is a T wave. You have a space where the heart's at rest, P wave, QRS, T wave, and ignore the kind of movement, P, QRS, T wave. You can see what a sinus rhythm means, okay, is that you're going to see that the sinus, what we're going to call the SA node, every time you have a beat, which is represented by this thing called a P wave, is followed by a QRS. That is a sinus rhythm. You hear it on TV all the time when they shock somebody. Oh, they're back in sinus rhythm. Well, that doesn't mean anything else other than you're going to see evidence of a P wave followed by a QRS. If they say normal, it has to do with how fast it's going. Normal means that the time between beats is between 60 and 100. So you can calculate 60 to 100 beats, which you'll get good at if you're doing this. Many of you will just count the squares between the peaks. And if it's 20 squares or 19 squares, you'll know immediately, is it 70, their heart rate 75, 70, 68, whatever. Just by doing it a lot, boom, that's a fast way to do it. There. Nowadays, you don't have to worry because it's presented digitally for you anyway on those monitors. Just saying, but there are times when the monitors don't work. So that's kind of what this is all about as a backstory. If you're curious what information you can derive from that, the appropriate term would be to infer from that. I will show you. And it gives me a chance to use the word infer. This is called the electrical axis of the heart. I had no idea. They didn't teach us this. But when I was a student, I had not learned about this as yet. It was not something they emphasized in my course of study. We didn't deal a lot with cardiac problems, but I wanted to learn. And here I was working as an elective, as an undergrad, as a student, as a medical student, and I see this first guy just graduated a month before, pulling out a little notebook when he's looking at a cardiogram he had just done. I said, what are you doing? He says, I'm determining the axis. Each of those leads, particularly these, they're not using all four. They're only using 3 at a time. And they represent a series of triangles about the heart. Triangle this way, a triangle, right side, left side, forwards, backwards, etc. They give you this axis. And what you do is you go back remember the names of the leads. So basically it says if both lead 1 and AVF have a positive and they're looking at that QRS complex, that peak that's pointing up, that's normal. Remember where your heart, basically the beat comes from. It comes from the lower. So if you're looking at a person with their heart this way, it's down here. So normally, electrically, it would be, if you look at this as a quadrant, it would be down here in this lower right-hand quadrant. And then, because you think, here's the base of the heart, here's the apex of the heart. It would be more toward the apex. It could be up here if it was opposite, or it could be left or it could be right. And from that, just looking at that, if you want to know a diagnosis, all of a sudden you have some causes for, is it up here in what they call no man's land, northwest territory? Okay. Is it on the right? Is it on the left? I mean, some of them are obvious. On the right, maybe the right side is enlarged. Maybe there's chronic lung disease. That's what enlarges the right side. Maybe it's a myocardial infarction in a particular area. Maybe it's a pulmonary embolism. That's going to affect the right side of the heart. If it's on the left, okay, you can look for other things that are there. Other things that are there. So you can see a lot of them. If it's all the way up there opposite, maybe you did something dumb. You just put the wrong leads. You transpose them. Hey, one of the first things when something doesn't make sense to you, make sure I set it up properly. You getting the idea? Everybody makes mistakes, makes little ones. So you might find that interesting, and you can look through some of these if you're interested, and more often, perhaps even more so down the road, when you're sitting there with your degree in hand, and you have to take one of these courses or a graduate level course. Come back and look at this. Wouldn't hurt you. So off we go into the saga of that. So that's I think it's a very useful introductory nugget, and I'll show you on both of these PowerPoints. So we left off. This was the PowerPoint, and I'm not going to use it. I just wanted to point it out to you. This is kind of where we left off with the muscles, and then the recording of the electrical changes that occur during the cardiac cycle. And it said the deflections, the movement in the normal electrocardiogram or waves include, and these are the ones you will have to know: the P wave, the QRS, and the T wave. Remember, electrical events precede mechanical events. Why I'm making such a big deal of it. Down the road, we're going to look at one particular slide, which shows the cardiac cycle in relation to these electrical events, in relationship to the heart sounds, in relationship to various pressures, and it's really important. That's how you can understand better what's going on in the heart. Am I going to ask you a zillion questions about it? No. Down the road, but I'm going to ask you a few. So, moving on. So we're using it to assess the ability of the heart to conduct impulses. It tells if there's a blockage in one of these, either there's a damage in the system that sends the signal, or there's a damage in the muscle. Sometimes, and frequently, the cause of this is some kind of damage to the muscle. That would indicate that there was an old, whether recent or older, heart attack, what we call a myocardial infarction, depending on where the death of the tissue is. So these are really very, very relevant. And understand, people can have heart disease without having either knowledge of or actually not having suffered a heart attack. You're going to find out as we move on with this particular chapter the impact it's had on me. My dad went from being extraordinarily robust and healthy, though we didn't see the warning signs, and in 10 days he was gone, not surviving open heart surgery, which was shocked. And I mean, you want to get worse about that. For those that I haven't repeated this to the last 150 times, I'm going to be 74 in May. My dad was 74 on May 1st, but I'll be 74 on May 10th. From his birth year, my dad died, unfortunately, 3 months later. So I'm hoping to see you next semester. Which is why, you know, where I was last night doing cardio. I was there again, trying to keep up with these two people running next to me. I'm just going to walk. You guys can run. It's all right. Moving on. So the P wave represents atrial depolarization. Remember, this is electrical events. They're going to come before mechanical events. So the P wave is going to be the atria depolarizing. The QRS, because it's massive, are the ventricles depolarizing. Okay. And as you can see, before the contraction, electrical preceding mechanical. Also, that QRS is so massive that the atrial repolarization is hidden. Okay, much bigger event. And then lastly, you're going to see the T wave, which is the ventricles, which again are so big, a bit large, even though it's repolarization, which is not as powerful in a mechanical event or electrical event, rather. We can see it. Okay, and they're just going to show you these things and blah, 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 blah. But I'm going to go from that and go back to the one I'm kind of used to showing you and sort of take it backwards a little bit. So those are the electrical things that are there. And again, I talked about this a little bit, But again, just to remember the sequence, the SA node is your pacemaker. It's your pacemaker because these are the cells that are the leakiest, if you recall. If you go back and look at that graph, they basically leak most rapidly to go from when they complete repolarization and reach their bottom resting membrane potential, they quickly work their way up. That's kind of the way to look at it. That's the SA node. Now this is stuff you'll have to know. The location for the SA node is in the right atria. The AV node, or atrioventricular node, next stop of any consequence for us, is in the interatrial septa. Remember, by intent, the impulses are delayed at the AV node. It just has less of them. Okay, that gives the atria a sufficient amount of time to basically, as I call it, top off the tank, or to contract and allow the ventricles to maximally fill. After that, it zooms super fast. It immediately goes very, very quickly through the AV bundle, the only connection between the atria and the ventricles, by way of bundle branches all the way down to what we typically call the Purkinje's, but someone will surely call it subendocardial conducting network. So voila, that's what makes it the pacemaker. And again, the significant feature there, the healthier you are, the more active your parasympathetic nervous system is, your vagus nerve keeping you together. Like I said, I've been very happy with what's going on when you're out of shape. Your heart rate is high, and when you go on like a treadmill or any aerobic exercise, you get started, all of a sudden that heart rate's going up a whole lot quicker than it really should. It should take you 5, 7, 10 minutes before you get into that zone where you're supposed to be. For someone of my age, probably between 110 and 120. For you guys, it would be obviously a bit higher. There's a lot of formula for the way you do that if you did not know. I mean, the easy way is take 220, subtract your age, and take 80% of that, roughly. And for me, that would, if I just use 70 as a round number, that would take me to around 120. I'm a little older than that, so maybe 115, 120. And the healthier you are, it's going to take you more time to get that. So you have to increase your speed and your elevation the way I do it, because I ain't running on the treadmill. It's okay. I broke up with a girl because I'm not going to run for a bus. I'll wait for the next one. But I'll walk for the bus. Sorry, she was a little shook. And at the AV node, it's delayed at least 1/10 of a second. That's important. Fibers are smaller, fewer gap junctions. Make sure the atria complete contraction. Again, this is an alternate, as you will see shortly. Can take over, shouldn't. Here's the connection. Here are the bundle branches. Here are the Purkinje's. Yeah, they could do it, but 30 is not enough to sustain life. And again, it's a relatively short. And here's a pretty similar illustration. The so-called internodal pathway that takes it from the SA node to both atria. They're depicting the AV node here. That's actually in the septa, but you're doing a drawing. The bundle, the right and left bundle branches, and the network that brings it up. So we're going to look at a normal rhythm, and then the implication is what goes wrong. We call them arrhythmias, a term you will hear a lot. I can look out here and see one. Automatic electronic defibrillator. Right? Sitting outside there, somewhere right here. They used to have one on the wall over there. I assume they still do. Why? Okay. Throwing it out generically. Years ago, I'm sorry, let's say all of us here, maybe many of you are, I would suspect, are current with CPR certification. If not, I'm sure you will be very soon. So if you witness an arrest, somebody's over there and all of a sudden clutches their chest and goes down, and you go over and that heart's not beating, that's called a witnessed arrest. If you just do CPR, alone, the odds on them surviving are 85 to 95%. Now, that may sound great, and years ago it was. But they found out if it was a rhythm that had an arrhythmia that was shockable, an arrhythmia that would be benefit by defibrillating it, you reduced the death rate or increased the survival rate to between 95 and 99%. Do not think that if you have a witnessed arrest, that the fact that somebody could be on there who's trained and knows what to do with CPR is going to magically save their life. You just can't survive them all. Sometimes they're just too massive. Simple as that. So a lot of that research is done. State of Washington was really the founder of CPR and related studies. Their health department did a lot of that. So because of that study, defibrillators, and anybody can use them because now with the computer chips, basically all you have to do is have from what I understand, I've never used one, self-explanatory. All you have to do is put those pads on directly on somebody's skin in the appropriate places, and they'll tell you, the chip in there, once you turn the machine on, will not only tell you if it should be shocked, it will basically tell you shock it into what level and do it automatically. Just the most important thing is everybody else can't be touching the person, they're going to get the shock. So everybody will have to clear. And hopefully that will do. And the whole idea of that is, the theory is if you can shock the heart, it will cause all of the cells to depolarize and fire simultaneously. The heart has an absolute refractory period. Once they all have to relax, and theoretically, if it's still functional, that pacemaker, the SA node, will take over. If not, maybe the AV node. And you will get some kind of a rhythm, hopefully a sinus rhythm, hopefully a normal sinus rhythm. That's the ballgame. Where does it all come from? So we're going to look at that. Fibrillations, very bad. Fibrillations are, whether they occur, if they start in the atria, they're going to go to the ventricle, because effectively these are random contractions of the muscle that are inefficient in pumping the blood either from the atria to the ventricles or from the ventricles to the lung or to the rest of the body. And they are doomed to failure. Eventually that heart is going to end up stopping sooner than later, considerably sooner. So atrial fib will lead to VFib or ventricular fibs. We'll call it AFib and VFib eventually, and you'll see, it'll show you this rhythm. So the treatment for either of those is this, effectively, they describe it as a bag of worms. And unfortunately, it's something I have felt. I'm not going to go into the story. In lab, I talk about it when I do the AP2 lab. I told my lab about it, so I'll tell you guys just briefly. If you did not know, 50 years ago, when medical students did live animal experiments and sacrificed the animals, it's very hard. Even as I reflect back on it, it's awful that an animal would have to die for us to learn something. We did not have modern technology. We did not have the ability to do these things. I have no idea how it's taught now. I honestly do not. Okay, I have not been in a teaching hospital environment or a medical school environment for many, many years. Once I went into practice, I was a clinical faculty member. But once I went into practice, we're talking the better part of 45 years. So suffice it to say that it's a very vivid learning experience that I would not wish on anybody to repeat. So nevertheless, I've actually felt that chaotic. This is called a bag of worms, like you're going, like I would go fishing. Like you got a bag of dirt and had the worms in it, a paper bag, and you could feel it sort of randomly moving around. Not that I would do that. I don't fish. I'm sorry. No hunting, no fishing. I go to the casino. I watch sports. That's enough drama for me. My wife goes camping. My wife likes to go fishing. She's into it. So sometimes you'll have, when the SA node isn't working, the beat has to go somewhere if you're going to have any survival. We call that an ectopic. Ectopic isn't just about pregnancies. Ectopic is something occurring where it shouldn't be occurring. So it's in an unusual location, or abnormal location. In that case, the AV node takes over. We call it a junctional or nodal, NODAL rhythm. okay, but it's not sufficient to permit any real degree of activity, and it's going to limit someone's ability to survive long term. A lot of us have extra beats. The most common cause, caffeine, by far and away today. Caffeine and nicotine. I was addicted to both of those, but now it's just the caffeine. And what happens is you can it's correctable, particularly the caffeine one. I mean, you can deal with that, and so it's not unusual. You'll feel those. If it's something that occurs randomly or at a regular basis, you'll learn about things called regularly irregular and regularly regular, and know which ones are to be alarmed about and which ones are not. Okay, and so effectively you're going to see varying degrees of what we call heart block. Heart block means that the signal going from the AV node, from the SA node, is either not getting through or only partially getting through, or for some reason delayed. Now we do relative degrees of heart block. If it's the signal is delayed, and this is really one of the first important areas you look at that we're covering today. If the signal is delayed, okay, we call it a first degree heart block. If every other signal, every third signal gets through, we call it a second degree heart block. And if the signal doesn't get through at all and the AV node takes over junctional or nodal rhythm, that's a third degree or total heart block. You don't have to go crazy with that stuff. I'm just trying to give you some context down the road that are there. If you have to know any of this stuff, I will let you know. And yeah, a lot of times the treatment for these are pacemakers. And so something I will show you. And so there are different things that modify it. The sympathetic nerves will try to make it accelerate. Okay, it'll stimulate the SA and AV nodes, heart muscle, and the coronaries. And if necessary, desirably so, a healthy heart, the inhibitory center predominates. It holds it in check. Your normal heart rate would be over 100. The healthier you are, the more active your parasympathetic is in holding that in check at rest. Just showing you illustration. Again, it's mostly muscle. How does it basically do its thing? So involved in creating an action potential. So what happens when it reaches that? And that signal, and it's going to reach it, okay, it's going to open these fast voltage gated sodium channels. Sodium will enter the cell. Again, it's just like any of these fast channels that generate an action potential. Effectively, there's positive feedback. You can see it's a big jump. Minus 90 to plus 30 millivolts. So it's over 100, 120 millivolts that are there. At the same time, we get slow calcium channels. Calcium is a big player. Extracellular calcium. And what it does, even though the sodium channels are closing, these calcium channels remain open, so they prolong. This is not a skeletal muscle. It's not a nerve. It's not up, down very quickly. There's a more prolonged plateau. And then after about 200 milliseconds, the calcium channels close and the voltage-gated potassium channels are open. And that allows the potassium to go out, take it back to the resting membrane potential. The calcium is pumped both back. There's some in the sarcoplasmic reticulum, but most of it's extracellular in nature. So what's the difference between skeletal muscle and heart muscle? Very short action potential. Heart muscle, 200 milliseconds. Okay, so the action potential, contraction, again, considerably longer. The action potential, very brief. The contraction, relatively brief, which is long and long. The benefit of the longer action potential and contraction ensures efficient ejection of the blood, and that longer refractory period prevents tetanic contraction. When someone says they have a heart spasm, they can't. That's because of the absolute refractory period. The heart muscle, it guaranteed for about a quarter of a second after every beat, it's got to rest. It can't physiologically contract again. That's protection. Someone may sense a spasm and associate the pain and say, oh, I'm having a heart spasm. You're not. It's not the same as getting a Charlie horse or a spasm in your muscle that's there or inducing it in the laboratory. You can't do it. Physiologically impossible. So they're showing it to you a little bit. Here, the action potential, the sharp spike, the plateau, and the repolarization. And here you can see the tension going up and down. And look, roughly, you have that arbitrarily, let's call it for argument's sake, about a quarter of a second, maybe it's a skosh less, where it's not. Until you fall below that threshold level, you can't possibly contract it. Then you have, to some degree, a relative refractory period. We may take a little extra juice, so to speak, to be able to contract it. Important. Really important. So what do we see on the EKG or ECG? All of the action potentials together. The 12 lead is most typical. These are the important waves. The P wave, signifying depolarization of the SA node and the atria. The QRS, ventricle dipole and atrial repole. The T wave, ventricular repolarization. We look closely at these intervals. PR, because that's whether or not the signal is getting through, and if so, is it getting through efficiently and normally? Okay, the ST segment, because it tells us about the ventricular myocardium, as well as being depolarized, as well as repolarized. That's important because that's where we can start to see if there's significant damage vis-a-vis a heart attack. So we're looking at particularly the ST segment almost as much as anything else. There you can see an older gentleman. You can see the typical limb leads here, those four, and we use colored leads so everybody can put them on easily. And now you can see the precordial leads all the way around that are there. And this is very, very standard. A lot of times they're checking your blood pressure. Because I've had this done a bunch. Here it is. P wave. So this is picking one isolated segment out of cycle. These are those little squares. Each one of those squares is 0.04 seconds. The normal interval between the start of the P wave and the start of the QRS, you can see the Q typically goes down a skosh because it's such a vigorous reaction. It goes down a skosh, goes all the way up, and peaks, and rapidly goes down, kind of overshooting that baseline. That's the typical QRS. And then it's flat, and we go to the T, the ventricular repolarization. They're depicting here normal. It should be between 3 and 5 of these little squares, roughly between 0.10 to around 0.20, from a tenth to a fifth of a second. So this one is 0.16. If you calculate the 4 squares, that's normal, somewhere in that range. There's no right or wrong. It's just to be in the right range. That's the normal we call the PR interval or PQ interval. They're typically probably calling it PR interval. This is the ST segment. It should be flat going into the T. It shouldn't be up here or down here. This would be an elevated ST. This would be a depressed ST. That's signifying real irregularities in the ventricular myocardium. That's one of those, oh my goodness, signs that we're having, that there's already been some damage. And a lot of times when we see irregular Q waves that are very enlarged or very deep or going in the wrong direction, that very often will point to potentially a heart attack that's happening right now or it's just happened. Broad brush. I am not a cardiologist. Again, we don't use these as much because we have better tests to be able to identify whether this is happening right now. But that's part of it. And then we also, for an enlarged heart, this spike shouldn't be pretty much more than, this is about 100 millivolts tops. When it gets over that, when you have a very, very large spike going up, it typically points to an enlarged heart. Enlarged heart, something called cardiomegaly. Megaly means big or enlarged. Cardio is heart. Typically means the heart has been enlarged, and the reason for that is high blood pressure. Because your heart has to work, there's so much opposition from your blood pressure, your heart has to work super hard to push the blood around. It's like any muscle that's overworked. It may be beneficial early on, but eventually the heart becomes effectively muscle bound. And it can't. You remember what happens when the muscles are already contracted? They can't generate the force. Remember, mass times acceleration, the length, there's not enough length in it. So that's one of those muscles you can overload. And that's what happens with it. And they're just showing you the images that are associated with it. So there's a lot of information there. So changes in the patterns of the timing may reveal a diseased or damaged heart with problems. Problems that can be detected: the R wave and large ventricles, that big spike, elevated or depressed ST. So lack of blood supply, ischemia, tissue being bereft of or limited blood supply is going to be weakened. It's going to show elevated or depressed STs. And then that QT interval repolarization abnormality, maybe there's something going on in the ventricles. There's all these things to look at. You can look at them. There'd be a zillion references online. There are books about it you can find online. They're probably available without having to purchase them. I think there's a lot of resources. And eventually, this is what a normal tracing. So having done this one many times, if you count the squares, I mean, you have roughly 17 to 18. So there's 10 here, 4 on this side, 3. And it's actually going to be about 75 beats per minute. You can do the math and figure out, but that's the quick look-see. And you can see P, QRST, P, QRST. So not only this is a sinus rhythm, this is a normal sinus rhythm because the rate is between 60 and 100. Again, with the exception of the highly trained athletic individual. So, you can qualify normality. This is the junctional rhythm. As I find of saying it, the P waves are not there. So all you have is a QRS and a T. And you can see the T wave there's the ST segment is depressed. You can see how long it is. There's 1, 2, 3, 4, 5. So you have a minimum. So now here's your 1 second, and you can see how prolonged it is. This is probably it's between 40 and 60. It's probably around 50 beats per second. And even though it appears to be very forceful, there's not a lot happening with the atria. You're just not generating enough blood supply over time. Like I said, any degree of activity for an individual like this, problem. Years ago, they used to use heart medications to deal with arrhythmias. The medications were harsh. So believe me, the favored way to do it today is with implanting, and they've improved them. There were some big problems with these. They implant pacemakers. And with the pacemaker, they have to put leads in the atria and leads in the ventricle because there's typically the connection between the two, that AV bundle, not working so good. And something the technology has become much, much more advanced, and I'm sure will continue to be so with my limited knowledge. I know that was in my mom's day and age, and my mother-in-law at the time, her day and age, they were very reluctant because back then, I mean, this is 1980, 1990, not that terribly long ago. Somebody got a pacemaker. They didn't, 5 years later, they were gone. So the technology's improved a lot. So I remember my mom saying, I'm not getting a pacemaker. Everybody knows who's gotten a pacemaker. It's gone in 5 years. So she goes, I might as well just save myself the surgery. This is when he talks about heart block. So this would be, another way to express this is total heart block. No P waves are getting through. We call this second degree because P wave, QRS, doesn't look great. T wave, P wave, nothing. P wave, QRS, T wave. So it's every other getting through. 2 to 1 block. Second degree block. If all we saw, going back to the first one, if we saw that this was, and you can count the squares, it's about three or so squares. If this was elongated, that would be a first degree heart block. I do not know the terminology they're using today. That was the terminology we did, and this is all bad. This is very, very famous VFib. When you see this kind of a pattern, nothing's happening. Random action potentials that are throughout the ventricles, because the atrial ones would be very tiny. Chaotic is a good word, grossly abnormal. And typically we see that the next thing you're going to see, that heart's going to stop and you're going to have a flat line. At that point, you're in trouble. If the heart is flatlined, there's no electrical activity. Shocking it isn't going to help you. So what you have to do when it's flatlined, who's ever calling the code, who's ever administering it, let's say if there's an EMT on site, they would use an epinephrine jolt. In the old days, they would even do it intracardiac, but they would use something, maybe an EpiPen that they have in their kit, be able to use that directly to try, because you got to get some kind of a rhythm to have those, so that there has to be some electrical activity to defibrillate. So there's a whole lot of nuances to this. And so that's really what all the good stuff for today. We'll stop it here. We'll go in Monday. We'll start looking really at the fillings and all this kind of stuff. And eventually, this is the big boy here. That's the illustration we have to know. Thank you, sir.
What about asymptomatic fibrillation?
Pardon me.
Are we going over that as well?
No. Well, I'll find one and show it to you. And I ask the question. Remind me next time.